Have you ever been told you might need surgery and immediately wondered what happens next and maybe what questions to ask?
Welcome to What Brings You In Today, a podcast from SGMC Health.
I'm Erica Bennett.
And I'm Kara Hope Rockwell. And today we're here with General Surgeon Jared Sanders. So, Dr. Sanders, what brings you in today?
Well, yeah, I'm here today to kind of answer whatever questions y'all might have or whatever you think the general public might be interested in, whether it be in regards to general surgery or the breadth of what we do or trauma, whatever. You know, I'm game for whatever and excited.
So give us some background on your career journey. How did you get here to SGMC Health?
Well, I grew up in Americus, Georgia, went to Lee County schools pretty much, all the way 2nd through 12th grade. So I've always been kind of in the area. And my dad was an auditor for the state of Georgia and would audit school systems. And Valdosta has big school systems. It's got, both the city and the county and then the college and the technical school. And so our summer vacation was in Valdosta, which was like the big city for me. And we'd come stay a whole week while my dad audited these school systems over here. And so that was my familiarity with Valdosta, was growing up and kind of coming to the big city. And when I was graduating, I went to Georgia Southwestern right there in America. So, always kind of been around this area. I actually was a school teacher for a couple of years, taught 7th grade math and science up in Henry County, Georgia. Figured out 7th grade's a lot more difficult, than I was looking for. And somehow, kind of stumbled back to original plans I had when I first went to college that had kind of faded away and wanting to go into medicine. Not even knowing exactly what field at that time, but just always having that kind of pull towards medicine. And so started pursuing that, studying for MCATs and doing a lot of shadowing and rotations, and did a lot of shadowing in Plains, Georgia, which was, where I was from, and working with physicians at the hospital there in Sumter County back at that time was not part of Phoebe. It was his own hospital. This was before they had the big tornado that tore it down. And so I was there kind of during all of that. And so it was a unique, period of when they were struggling and trying to figure out how to provide health care in a time of turmoil. And so all that kind of really stuck with me. And I think that's where I picked up some of that, liking the trauma and liking some of the general surgery kind of broad aspects, because I always seemed to be shadowing with general practitioners who did some surgery. Back in the old days, you didn't have to be a surgeon. And then some of those that were surgeons kind of there that were general surgeons that did a little bit of everything. And so when I did get into medical school at Mercer in Macon, I was the last class that all 60 of us was right there and entered in Macon at the same time, but they had started branching off and sending kind of their your clinical years, your 3rd and 4th year, were starting to go to Savannah. They'd split the class and kind of send them, similar to what we're doing right now with having students from Mercer for their 3rd and 4th year. So I did that when Savannah first started, before they had their medical school. And so I did my clinical years out there in Savannah. Really loved the surgeons that I encountered out there. I liked a lot about Savannah and the hospital, their memorial that I was at. And then, decided to go into residency and went into Greenville, South Carolina. Spent 5 years in Greenville, South Carolina, which is, a beautiful place to be if you've never been. Very hard. I had my 2 children up there with my wife, Lizzie, and very difficult to get her to want to move her and those 2 kids down from Greenville, as it is such an attractive city. But we both knew we wanted to be back closer to home. She's from Sandersville, Georgia, has a big pool there, and so, that's a very small town as well. And so we just always kind of wanted to be back in a smaller community. And it was about my 3rd year I was on my pediatric surgery rotation, actually, up in Greenville. My program director knew I always wanted to do general surgery. Very few know that they were going to do just general surgery coming in, but I always knew I wanted to do just general surgery. And never wanted to go and, highly specialize or be in a big city or anything like that. And he came and found me. He's like, listen, I got this sent to me in the mail, and you're going to go to it. And it was this rural health recruitment clinic put on by the Rural Health Alliance for the state of Georgia. And so it was up at Lake Lanier in Georgia, and which isn't too far from Greenville, South Carolina. So he sent me to it for the weekend. The residency program did, and that's when I ran into Dr. Kim McGow and Leonard Parker, who were there representing South Georgia Medical Center, and they said, we've got some surgeons that we think you'd get along great with, and put me in touch with Miller Parker at that time. And so that's kind of, those guys brought me
What a
down a couple
blessing
times.
that you went to that conference.
Yeah.
Yeah, it's just random chance. And I'd always remembered Valdosta with fond memories, and then, met those guys, and I knew they'd be great teachers and mentors, and so they had an unbelievable reputation at that time, and I mean, of course, still do, but I mean, I just knew that it was a place that, had a lot of ability to train me in as well as to be in that community for a long time. And so that's what I was interested in looking for.
And what year did you join SGMC Health?
So it was 2016. I joined in 2016, the summer of 2016.
So we're 10 years.
Yes, it is. We're hitting on 10 years.
I mean, you said that you were a teacher. You're like, teaching's not for me. I'm going to go do surgery.
Yeah, I know, that's
surgery's
crazy.
easier. It is. It's
wild.
much, seventh grade
That's right,
is much
middle
harder than
schoolers,
this.
yeah, middle
They
schoolers
earn
are
that
easy.
summer vacation. I tell you. And now it's shorter. I don't know.
Well, tell us a little bit about general surgery. So we kind of prefaced it in the intro. Like when someone hears that they might have to have surgery, what kind of surgeries? General surgery is general. So like, how
Correct.
do you liken that to the average person that might have to have surgery at some point?
No, it's a very good question. I get asked it all the time. Probably the number one question you get asked. So what do you do? Type sort of thing. And it's a little breadth of all fields. We want to. In a town like this, you can't house a bunch of specialists. You can't be just the colon doctor, or you can't be just, a liver doctor. You have to, broaden and be able to take care of a little bit of everything. One, just because, the ability to be able to have the business for the hospital to be able to, keep you there and keep you happy. You don't want to have a physician come in who's not getting any busy. They don't feel like they're meeting their self-actualization of being, utilized. And so you got to be able to do a little bit of everything. And then because of that, you do end up getting quite a bit of volume. And so we'll treat anything from whether it's skin cancer to, your normal, what we would consider acute care surgery issues, gallbladders, appendixes, bowel obstructions, diverticulitis. We also treat a breadth of cancers outside of like skin cancers or benign lesions. We also treat colon and rectal cancer. We do a lot of breast cancer. And some of my partners are more specialized. And, you've had Dr. Davis on, who's highly specialized in thyroid, parathyroid, adrenals, and endocrine tumors. And Dr. Howell's, colorectal trained. And so we each kind of have these niches and specialties. I, of course, have always been drawn to breast cancer. And there's overlap between, each of us. We all kind of cover each other. And then we all do the trauma, and we all do the acute care surgery. And we brought in recently some young general surgeons that are bringing their skill set, such as Dr. Linhart with bariatric surgery, who also does general surgery. So, even though you may have specialties, you still kind of cover that broad range of stuff. And it always keeps it interesting, our job. And it's not the same thing every day, I can promise you that.
How do you ease patients' fears from having surgery?
The good thing with being a general surgeon is that you get a lot of volume. We're some of the highest volume surgeons out there for sure. And so, you have a confidence that comes with repetition. And that everybody knows. The more you do, the more repetition you do, the more familiar you get with it, the more confidence you have in yourself. And I think that patients can see that and feel that. And, I think it also comes from learning, what are your limitations and knowing what they are. And so I'm very honest with patients. If I ever feel that there's something that I can't do, or there's somebody who does it better, especially with us being surrounded with such, really good tertiary centers in Mayo and Shands right around, the corner, then I will send them there. And I have no problem sending anybody there. And I think, when I talk to them and explain to them that these are things we do every day, and I don't think you need a specialized center versus, hey, if I ever thought you did, and I think we do in this scenario, I'm going to send you there because they do this on a weekly basis. I see this maybe every 2 or 3 months, sometimes less than that. And so, we have good relationships with those referring facilities and the surgeons at those facilities, whether it be like liver surgery or hepatobiliary surgery, some complicated colorectal stuff that we don't do here. We send them to those guys and keep in touch and tabs and try and help out, how we can on this side. But I think it's just, knowing that when you're speaking to them, you're speaking to them from experience and confidence, and it takes a while to get that. And obviously, I didn't have it to begin with, and I appreciate my first 3 years of patience, trusting me and things going well. But you grow very fast in this field, and it's, again, you never know what you're going to get. So prepping, people are like, it's not like I know what case I'm doing in 3 weeks. I mean, I was on call last night, and I didn't know what 2 cases I was doing this morning, and I just did them. So you just don't know, and I think that also makes you more well-rounded and better to handle whatever circumstances or complications may arise during your surgery. But it's communication and honesty and being willing to show your humility. It's not a pride thing getting somebody to somewhere else where they need to be. I mean, that's just part of the job.
Well, I think you're well known for your just genuine personality, your skill, but also your character is
appreciate that.
Evident through all of our patient reviews that we get from your patients. So I commend you. You are doing very well on that. Kind of speaking on that trauma, because you're talking about unexpected things, you were very integral into the development of our trauma program here at SGMC Health and getting that started and kicked off. So tell us a little bit about that and kind of maybe where it is now and what all had to happen for that.
Well, I'll be honest, we were already doing so much of the work. We're even though we're near those trauma centers, we're still over an hour away, even by ambulance at high speed. I mean, we were still somewhat isolated and right here on 75. So we were getting already some pretty significant traumas, and we keep quite the vast majority of what we get doesn't get transferred out. So we were already doing it. We just needed to be getting the credit for it more than anything. And we needed to highlight, specific areas. And in doing that, when you start to work on these things and putting them together and realize, we can improve in some areas too, though. And we started, redefining certain protocols we had and adjusting them and making them better and more rapidly available, such as like massive transfusion protocols. We've got that in place to where blood is much more readily available to patients as soon as they get here. We can almost moving those products even closer to the proximity of actually being in the ER rather than having to get them from the lab. Making it a much more streamlined process so that when a trauma alert does go out and EMS calls it in, that when the patient gets here, all teams that are needed are there and ready to go. I mean, that's not just your ER doctors. It's not just the nurses. It's also having, respiratory there, having the lab there, having X-ray there, pharmacy there, and getting your surgeons on the way in. That's all now in place to where it happens in unison and at one time rather than just the phone tree going down. And so, each of these steps that we make, more protocoled and streamlined, we can also study them better, and we know how it's supposed to go. And we can check boxes off when we sit down and review cases. And it may be just a simple thing like, did they get their tetanus shot? Or did they get their antibiotics with an open fracture within a hour's time? We have goals that we outline, and it makes it easier to achieve these goals when we're paying attention to them and recording the data. So it just builds on itself. So not only do we start getting credit for what we're doing, but then we start doing it better. And we start tracking it better. And then we can report that. And I got to give huge credit. Anytime you mention trauma program, I'm a small part in it compared to, Emily Brown and what she did, and she's our EMS director. And she is very protocol-driven individual and a very type A individual when it comes to that kind of stuff. And you've got to have someone like that on board to get something started like this, because I think it happened where it started up and just kind of died down a couple of times, and she was just a bulldog and saw it through to the end and just drug me along with her, So you also had to have a motivated colleagues and partners and having that support. Trauma protocols can be, a very time-consuming thing sometimes to the professionals having to be there, because trauma, most of it is non-operative. I mean, the vast majority of what we do is non-operative. So, to tell a surgeon they got to come in and get ready when they're probably not going to operate in the middle of the night, and they know that because you don't know what you're going to get. versus the old way of, getting called and saying, hey, we've got this that needs to go to OR. It takes a mindset change and a willingness, but, you save that time and lagway, and then you've got somebody there, too, that's familiar with trauma and can steer the direction of how the workup needs to go. And so that buy-in from the general surgeons and the neurosurgeons and the orthopedic surgeons is very important, to get somebody on. And we had a good shift in that helped us do that. Anesthesia as well is a big part of it. You don't think of it, but they're a big part of that as well.
Yeah, so SGMC Health became a Level 3 trauma center back in June 2023. So can you just explain a little bit, what does that really mean for a patient or a family?
Yeah, so, Level 1 and Level 2 trauma centers are obviously higher level. Level 1s are usually just your basically academic centers where you have residents and research coming out of them. Level 2s, for a functioning standpoint, have a lot of the same capabilities, if not almost all the same capabilities, and maybe just don't have the research requirements or the amount of or residents available and stuff like that. Are kind of the big difference between those two if you just want to surface level. A Level 3 program, really needs to have good ortho. We need to have good general surgery, of course, but then also we're not going to have all the specialties available, especially not in-house or 24/7. Those facilities have, your general surgeons are mainly in-house, or you've got residents in-house. And then they also have cardiothoracic surgery, which we have too here, and we have neurosurgery. But they're held to a little bit more tighter time frames maybe, or they also have plastic surgery that's always available, ENT or maxillofacial. They have the entire breadth of specialties that are needed, which we're just not able to. We don't have the manpower to be able to staff that 24/7 at our ER. Sometimes we do, sometimes we don't. And another big part is the pediatric side of things too, or burn centers that are kind of like affiliates to your trauma centers, and a lot of time, and even Level 1 trauma centers don't always have burn centers. So those are all kind of special scenarios too that we still rely on, and those are the patients that we mainly kind of transfer out, those pediatric or burn patients or the specialties that we just don't have coverage for. And ENT, urology, oral maxillofacial surgery, ophthalmology, those things are hard to get because a lot of those practices are almost private with their own surgery centers, and they don't necessarily have to be on call. I mean, one of our, ENTs or urologists, sometimes they cover, more shifts than they should, just helping out our community. And so we're very appreciative of that. But it is demanding when you only have one or two of those in the community versus you have 5 or 6 general surgeons that can split the call up.
Right.
So
makes sense. We've talked a little bit about trauma, but let's talk a little bit about another program that you helped kind of get off the ground, and that's our breast center.
Oh, I won't take any credit for that. That's that's Dr. Harvey Miller and Mary and the cancer center guys. That they're all, that's all their baby. And general surgery, we do the breast surgeries primarily, and then that's a whole team approach, and that's what that is. That the Breast Health Center is really a multidisciplinary committee where we at this time are try to review every single breast cancer case that is diagnosed at this hospital and treated, and that's where we all sit down together. And it's general surgery, it's medical oncology, it's radiation oncology, it's pathology, it's radiology, and then it's the care coordinators and nurse navigators are all at that meeting too, and we review the workup, we review the pathology, we review the surgeries, and then what we call either neoadjuvant or adjuvant, whether we treat beforehand with chemotherapy or we treat afterwards with chemotherapy and radiation. And we review kind of that whole process and have a plan for that patient before we actually start that journey of treatment. And that's been very beneficial too. It keeps everybody up to date. Kind of, each of these fields has its own research. most of the time that research all aligns very well. Sometimes there's kind of gray areas between those research, and having that multidisciplinary committee helps smooth those gray areas out, helps keep you up to date on what radiation oncology's literature's headed towards or doing nowadays, or oncology's things that I'm not going to pick up in Annals of Oncology. I'm going to read my own material, but at those meetings we can get feedback from each other, how things are heading and where treatment's going, because they are all very much so interwoven in a treatment plan. Breast cancer is one of those that's very much so interwoven, and it happens pretty quickly too. With moving from either, whether it be neoadjuvant treatment, which is where a patient may receive chemotherapy or monoclonal antibodies up front, and then move into surgery, and then right after that could go right into radiation only a couple weeks, 3 to 4 weeks later, and then back in to chemotherapy. So, I mean, it's a lot coming at a patient very quickly.
Yeah.
So when all of our doctors are all saying they've all talked and they're all on the same board with treatment plan, it gives a whole lot more confidence to that patient.
Absolutely.
When they're hearing the same thing from everybody. And we also can get those appointments in and more streamlined, so that, well, I'm supposed to see so-and-so 3 months. That's not going to work. When we have a meeting, they're going here, here, and here. And, of course, there's hiccups every now and then, but for the most part, what they've been able to do by pulling together that multidisciplinary committee has made communication significantly better, which in turn makes treatment better.
Yeah. What drew you to have a special interest in breast cancer surgery?
It's almost like anything. It kind of comes to you over time. It's not one day I just decided to do that. I mean, I came out doing general surgery. I did work with some surgical oncologists in Greenville that I liked a lot. I worked very well with them. They wanted me to go into surgical oncology as a specialty, but I, like I said, I didn't. You can't really be in Valdosta, Georgia, doing that.
Sure.
So I wanted to stay more broad. So there was always kind of that interest and gravitated to it. It's not that it's a technically difficult surgery by any means. From that standpoint. There are things, just like in anything you have to be careful with. You do have to, you work a lot with plastic surgery. You work a lot with like I said, the multidisciplinary and colleagues. It's something that, is a very high anxiety. Cancer, we're talking about 1 in 8 females. 1 in 8 females. That's what you ladies are born with. I mean, that's amazing. I mean, the prevalence is just unreal. 12% lifetime risk, and that's the best it gets. So I mean, the anxiety is unbelievable, and then we have some really strong genetic mutations that really increase, the cancer risk, and so I think my personality just kind of fell into it to where maybe I just was a little more patient with those patients and understanding, and maybe we just kind of gravitated towards each other over time. I think that's probably more of it than anything. And I don't know. I started liking more of that collegial approach to a disease where gallbladder, I don't need anybody, and appendix, you don't need anybody. I mean, a lot of those things, they're just surgeries, and and I love those surgeries. There's nothing better than an appendicitis or a gallbladder or a hemorrhoid. You take care of it, the patient's feeling much better the next day, and they go home. That's the best it gets, right? Yeah. And you love those, but this is more of a gradual process, and then surveillance over time, and so as a surgeon, you treat patients, and then they're better, and then you never see them again. Well, my breast cancer patients are different. I treat them, and then I follow them through their adjuvant treatments, and then they follow me, for their life, and I get to see them, and we check imaging yearly, and we do exams yearly, and we stay up to date on what's going on with oncology. So I got to have that little bit of,
that longitudinal care.
Yeah, that longitudinal care to a small town you kind of want. And so I think that appealed to me as well.
Do you see that breast cancer patients are trending younger?
I'd say, yeah, I do feel like it, just anecdotally,
Right.
I mean, just from what we see. I don't know if it's from we're doing a better job with surveillance, we're doing a better job identifying those families that are at risk and screening for genetic mutations and identifying them in younger, whether it be siblings or children.
Right.
But yeah, I do feel like, I've seen it get younger, and I feel like, aggressive more aggressive tumors in
Yeah.
younger patients too. Especially the African American population seems to have very aggressive tumors at younger ages. And so, it's, a very high anxiety thing. Females can have fibrocystic breast disease. They can feel lumps that are there one week and gone the next. And, and so you feel and you don't know, and then it's there or isn't it there, and you get an ultrasound, a mammogram, or when they don't see anything, but you still feel it. And then you've heard the story of somebody that has. So, I like working with that too, and trying to help reassurance. And we're getting, more in line with almost doing things the same way Mayo does. We had to get more MRI machines in. We had to increase the availability for that. We had to win insurance companies over time so they let us get the studies and getting these other tests that can help, in those scenarios. And it's just, always trying to stay up to what the standard of care is in every field. But it's more important in those younger patients too, that early detection, because of sometimes they do tend to be more aggressive tumors, more so than not.
So I hear so much in what you're talking about. I hear so much like leadership skills. I know you served as our chief of medical staff for 2 years, and then you're having to serve in these different roles to help develop programs and things like that, which is far outside of just doing surgery. Did you expect that when you went into school? And then what have you learned from that?
That's a good question. I don't know that I expected it, early on in career, but South Georgia Medical Center is very unique in how it's set up with its medical staff. You don't have a chief of staff that's hired on or in position for 10 plus years that's a near retired member of the medical staff community like you'll see in some other areas or you see on TV. Ours is a voted on by the medical staff, but it's a rolling position too, as well as the entire MEC, the Medical Executive Committee is. And I think that's great because it gets people involved in early on. It keeps that position kind of fresh. And so people earlier on in their career are coming into the positions. I started out as chair of the Department of Surgery and did that 2 years, and then did chief of staff elect for 2 years, and then went into the chief of staff position for 2 years, and now I'm post chief of staff, and somebody else is in each one of those roles. And it keeps the people in your department engaged and involved and moving into positions sooner. We also have other positions that kind of feed into those positions. And I think it's key that once somebody's been in our system here for 2 to 4 years, it's time for them to start getting involved with that leadership. Understanding, the roles of the Medical Executive Committee and what helps drive, care and quality. Those members also sit on both the medical and surgical quality committees where they review, cases, whether it be something from the ER or anesthesia or wherever in the Department of Surgery, OBGYN. We review them all as a multidisciplinary committee as well. And medicine mirrors the same thing on the other side. And so having people evolve through those roles, serve on those quality committees, as well as, even complaint and discipline committees. It's important to see the other side of all of that and do it early on. I think that's what helps your system grow. And now I'm 10 years in and I'm rotating off of that already. My kids are entering high school. It's kind of a perfect time to kind of do that too and spend some time. And, you feel like you've put some of your time in, and then you got the guys up under you, growing and doing it. I think it's a really, unique thing that happens here with the way they've arranged the medical staff. And so I think it's you kind of, Dr. Ziegler, one of my senior colleagues, he always says, you the leader, you get out of the way in the Department of General Surgery. And that's general surgery wants to be at the table for everything. Yeah. We want to keep somebody in those positions and moving up. Dr. Davis, who's been with me since medical school, he's the chief of staff elect. Now, we like being involved. We touch so many different departments at general surgery. We're involved with pathology. We're involved with the ER. We're involved with the OR, the ICU, the floor, the outpatient offices. We touch everything kind of in general surgery. And so we have those relations, and it's important for us to make sure we're involved in the decisions that goes on with all those departments, because it reflects back to us, but we also take a lot of pride. I think you'll find that all your general surgeons are very community invested here. We don't recruit anybody here to be here for 5 years. We recruit them to be here for 20 years, and that's our goal, you know.
Okay. All right. Well, I think that just about wraps us up, but there is one more question. What is your favorite meal to eat here at SGMC Health?
Corn dog.
Corn dog. That's
No
what I
one
get,
has
Birdie.
said
That's
corn
what I
dog.
get,
Go
Birdie.
straight to the corn dog. That's what I eat.
They're good. They are good.
That's funny.
Well, we appreciate you being
Thank
on
you all.
Dr.
No,
Sanders.
thank you for having me on. I
And thank you
appreciate
for
it.
all of your leadership and your service to our
Well, thank you.
organization. You have been a pleasure to work with. So
Well, I thank you for the opportunity that SGMC has given me, and I appreciate my patients in the community. I do.
All right, well, that wraps us up. If there's any topics you're interested in or any particular guest you'd like for us to have on, you can let us know at sgmc.org/podcast. And don't forget to like and subscribe.